السلام عليكم. أحبائي المرحلة الرابعة اليوم نكمل محاضرة الامبوليزم. حكينا المحاضرة السابقة عن الامبوليزم والكلينيكال برزنتيشن. We divide the presentation in three types: major اللي هي massive emboli, and moderate involving the medium-sized pulmonary artery, and the chronic type اللي هو involving the small arteries, and the presentation differ from each type. And we discussed the diagnosis, how we diagnose embolism by the usual investigation starting from the ECG and echocardiography, CT angio, and even Doppler ultrasound. And lastly, we discussed the test. We call it the dimer, and we call that the dimer is very important for the exclusion, not for diagnosis. Why? Because they present in many conditions, like MI, like pneumonia, sepsis, and so on. So the importance of the dimer come with these criteria اللي هي Wills criteria أو يسموها likelihood for the embolism. We have many points which include the history point, symptom, sign, and even the experience, clinical experience judgment. So the point of if the patient having previous venous thromboembolism like DVT, or having previous cranial intracranial thrombosis like in venous thrombosis and so on, giving 1.5 point. If patient having recent surgery سواء كان fracture femur أو مثلا cesarean أو bedridden for any cause in case of مثلا of severe illness, giving 1.5. Cancer 1 score. If the patient having coughing of blood and we call it hemoptysis, is just 1. If the patient having sign in tachycardia, increasing heart rate more than 100, giving 1.5 score. If the patient have a clinical sign of DVT, giving score 3. The clinical judgment depends on the experience, which is if the patient less likely to have other diagnosis, giving 3. So we collect this point or this score. If the point less than 2 and the patient having negative dimer, so the likelihood for embolism is thromboembolism is low and diagnosis is cancelled. If moderate, we go to the investigation more. If we high, we go for diagnosis. So this point make the likelihood for embolism either low or high or moderate. So this diagram we discuss the same point. If the patient have suspicion of embolism, we assess the clinical sign risk by Wills criteria and measure the dimer. If the dimer negative and the patient having low probability or low likelihood, so there is no embolism. If the patient having negative dimer and high risk group, we direct for the investigation. If the patient have positive dimer and the risk is high, we treat and confirm diagnosis. If the risk is low, we send for the investigation. What are investigation we support, as we discussed? Ultrasound, CT angio, and the ventilation infusion scan, which is nowadays not useful, not used in practice. This is the diagram showing the way to diagnose the embolism or to start treatment. Now the management of embolism, as we talk, a patient having massive emboli, so the early recognition, early diagnosis is useful for life saving. If the patient delayed diagnosis, the patient may be died. And also this point, most patients with embolism having hypoxia, decreasing oxygen less than 90. So we try to maintain oxygen more than 90 by giving high flow oxygen. And also some condition we use supportive therapy for the shock by the fluid, intravenous fluid, the crystalloid or plasma expander. Sometimes we used some drugs here, inotropic drug, which is increase the heart contractility to increase the blood pressure, but this drugs in massive emboli is less likely useful because the the heart is maximally stimulated by the endogenous catecholamine. And lastly, opiate can be used, but with caution for the hypotensive effect, because it causes vasodilatation. And resuscitation with the massage, CPR, can cause or can be useful in some condition in the slowing of the thrombi, causing improvement of the condition. So this is the primary point. We do oxygen, opiate, and supportive therapy, and then we start the treatment. Treatment depends on the severity of the embolism. If we have medium-sized or moderate type embolism, not massive, the patient يكون conscious, having pneumotensive, having pleurisy and sign of embolism, we start anticoagulation. هنا drugs used for anticoagulation we are used to prevent propagation of a thrombi, not lysis thrombi. That's the differentiation. Anticoagulation used to prevent propagation of a thrombi, used in case of moderate embolism, and usually we start with the parenteral type اللي هي اما اللي هي الهيبارين العادي يسمونه انفكشن هيبارين، او الهيبارين اللي هو لوميكال هيبارين اللي هو انوكسابايرين، او اللي فوندوبارنكس اللي هي also يشبه الانوكسابايرين also is parenteral anticoagulant. So this is useful for prevent propagation of a thrombi. And these parenteral used as a bridge to the oral type, oral treatment اللي هو warfarin اللي هو considered as vitamin K antagonist, factor antagonist, and useful to get full action, which require about 3 days. And we give a bridge treatment till the oral therapy completely effective. We stop the parenteral and continue on the oral treatment till the period required according to the cause of the embolism. Fondaparinux اللي هو anti-factor 10 pentasaccharide, which is closely related to the heparin, and administered by once daily sub-injection, and useful and provide FDA to treat DVT and embolism. The agent used in the treatment of embolism اللي هو enoxaparin, which is commonly used, is 1 mg per kg in twice dose, or 1.5 mg per kg in once dose. Deltapirin, tenzapirin, and fondaparinux اللي هو can be used also once daily injection depending on the body weight. So this is the parenteral treatment. And the new agent also having some improved and some under research and some under study اللي هو direct thrombin inhibitor اللي هو دابلتران اللي هو مادرسة oral anti-thrombin, and IV اللي هي heriodine and other group اللي هي can be useful in case of heparin-induced thrombocytopenia, and synthetic pentasaccharide, activated potency, tissue factor pathway inhibitor TFPI, and factor 10 inhibitor, which is also available اللي هو rivaroxaban اللي هو Xarelto, and the other member in the group, which is useful as oral treatment anticoagulation. So this is the anticoagulant used in the case moderate or maintenance after massive emboli. Now we talk about the duration. Duration depends on the cause. In patient having cause non-cause يعني reversible cause, مثلا case done cesarean section or fracture femur and develop embolism, أو مثلا RTA develop embolism, so the factor or the risk factor is temporary, so usually giving treatment for 3 months is enough for anticoagulation. But some patient having persistent thrombotic like مثلا vasculitis أو antiphosphate syndrome, أو مثلا patient having chronic disease, or patient having continuous risk for thromboembolism, we use anticoagulation for life. In patient with cancer, usually preferable to use parenteral اللي هو enoxaparin أو for 6 months at least. Now we come to other type of thrombolytic therapy. الثرومبوليتيك ثيرابي يختلف عن الانتيكوagulation، هو causing lysis of the thrombi and useful in case of massive emboli we diagnosed by the investigation and the patient having massive manifestation, having severe shock, severe collapse, and even having decreased cardiac output, and so require mass thrombolytic therapy. Thrombolytic usually given in patient with cardiac shock due to massive emboli. If the patient having no shock but having massive emboli and right RV ventricular dilatation or failure and severe hypoxemia also can be give a thrombolytic therapy. Sometimes if the patient present in some centers available for embolectomy, we can do surgical embolectomy, but may have high mortality or high mortality risk in some condition. So this is the thrombolytic therapy. Thrombolytic therapy differ from the anticoagulation by the lysis. بنقول الثرومبوليتيك هو lysis of the thrombi. الانتيكوagulation هو prevention of propagation. ما يفيدنا ما يسوي lysis for thrombi، لكن thrombolytic يسوي lysis for thrombi useful in the massive emboli. Usually we use TBA اللي هو plasma activator and alteplase اللي هو giving 100 mg over 2 hours, and usually the response come with the 14 days. But in the video we show in the last lecture, and we get the response in the second day. Okay, so it's very useful in massive emboli. Now the embolectomy, as we talk, this is the clot which block the major pulmonary artery and the major branch and removed by surgically. You see, this is the clot seen in the pulmonary artery, and the patient respond to the embolectomy, which is useful in some centers. Now we reached the end of our lecture with KL filter. This filter like this شلون المصفاية نسميها. This filter in case of patient having DVT and having embolism, but unfortunately we cannot give anticoagulant or even anti-thrombotic. So those patients sometimes مثلا patient مثلا عندنا قبل مدة دخل المريض صار عنده embolism وانطيناه وقت massive embolism وانطيناه actylase، لكنها unfortunately develop intracranial hemorrhage, small intracranial hemorrhage, and patient controlled and okay, but in the next 3 days he developed DVT of the other leg. So if we have intracranial hemorrhage, we cannot give more anticoagulation. So the choice to the filter is the okay, and we give we refer for the cava filter, and the filter put in the inferior vena cava to prevent the passage of the emboli to the upper pulmonary artery and getting improved until patient improved condition, and we can start other anticoagulation. So if the patient having contraindication to anticoagulation and having massive hemorrhage or massive peptic ulcer or massive bleeding for any source, so we can give inferior vena cava filter, which is useful to prevent as embolism as temporary measure. And this is the site of the embolism in the inferior vena cava, and we finished our lecture, and see you in the other lecture next week.